Hi and welcome back to another video of Medic Notes. This video is on variceal bleeding. Gastroesophageal varices are the most clinically important collaterals because their rupture results in potentially fatal hematemesis. The dilated submucosal veins in the lower third of esophageal is formed by the portocaval anastomosis, between the left gastric vein and esophageal branches of azygous vein. For its risk factors, prevalence of gastroesophageal varices increases in child's score. Score A is 40%, score C is 85%. Strongest predictor for development of varices in patients with cirrhosis is the hepatic venous pressure gradient of more than 10. Most important predictor of hemorrhage is the size of varices. Other predictors includes decompensated cirrhosis and endoscopic stigmata of recent hemorrhage. Variceal bleeding associated with mortality of at least 20% at 6 weeks. When to suspect variceal cause in upper GI bleeding. Any previous variceal bleed? Ask patient whether he or she goes for regular banding or OGD screening and banding. Any history of chronic liver disease? Ask for risk factors such as alcohol ingestion, hepatitis B and C, and is there any stigmata of chronic liver disease? For management of variceal bleed, it can be divided into 3 main categories. For active variceal bleed, for prophylaxis, and chronic management. For active variceal bleed in hemodynamically unstable patient, resuscitate and manage in critical care area. Maintain airway, keep in view for intubation if patient has altered mental state or hematemesis is copious. For breathing, give supplemental high-flow oxygen, maintain saturation more than 94%. Establish 2 or more large-bore peripheral IV lines, monitoring vitals, ECG, pulse oximeter, urine output. Request GXM4 units, and take necessary bloods. Infuse fluids 1 liter crystalloid fast and reassess parameters. ICU bed and facilities should be made available. Pharmacological management. IV broad-spectrum antibiotics for 7 days, ciprofloxacin or ceftriaxone. IV somatostatin or IV octreotide for 3 to 5 days. IV omeprazole 80 mg bolus and 8 mg per hour for 3 days. IV vitamin K should be given routinely to cirrhotic with coagulopathy. Can also consider terlipressin and recombinant activated factor 7. For management of severe variceal bleeding, balloon tamponade can be used. Protect the airway before inserting the SB tube. Sengstaken-Blakemore tube, maximum 24 hours, temporary deflate after 12 hours to prevent pressure necrosis in patients with uncontrollable bleeding for whom a more definitive therapy is planned, such as TIPSS or endoscopic therapy. The SB tube consists of gastric balloon, esophageal balloon, gastric opening, and esophageal opening. Other than that, endoscopy is a diagnostic and therapeutic method. Sclerotherapy can be done into bleeding varices or overlying mucosa, to induce inflammation and fibrosis. It controls bleeding in 70% after first injection and 85% after a second. Variceal band ligation. Ligation is superior to sclerotherapy in initial control of bleeding and has fewer adverse effects. For bleeding gastric varices along lesser curve, manage as per extension of esophageal varices. Whereas gastric varices along greater curve, evaluate splenic vein patency. If patent, manage with endoscopic gastric variceal obturation or consider TIPSS. TIPSS is transjugular intrahepatic portosystemic shunt. Indications are protracted bleeding, progression of coagulopathy, visceral hypoperfusion, refractory ascites. It involves radiologically guided intrahepatic placement of a stent between branches of the portal and hepatic venous circulation. Acute decompression of portal pressure, thus controlling refractory variceal bleed. However, TIPSS is not a good long-term preventive strategy. Next we go to the second category of management, for prophylaxis of variceal bleeding. Secondary prophylaxis of variceal bleeding. Patients with cirrhosis who survive an episode of active variceal bleed should receive therapy to prevent recurrent. Best option is combination of band ligation, 3 weekly ligation until completely obliterated, and non-selective beta blockers, propranolol unless contraindicated. Primary prophylaxis of variceal bleeding. Prevention of variceal hemorrhage in patients who have never bled, can reduce bleeding risk by 30 to 45%. Indications are large varices grade 3, or medium varices grade 2, with endoscopic red signs or child C cirrhosis. Best option is non-selective beta blockers, to reduce risk of bleeding and slow progression of small varices into larger ones. If contraindicated to beta blockers, consider long-acting nitrates like isosorbide mononitrate. These are some of the predictors of variceal hemorrhage. Site: gastroesophageal junction varices are at highest risk of rupture and bleeding. Size: Grade 1 are small straight varices not disappearing with insufflation. Grade 2 are enlarged tortuous varices that occupy less than 1/3 of the lumen. And Grade 3 are large varices that occupy more than 1/3 of the lumen. Child score: Patients with higher child score have higher risk. Red signs and endoscopic stigmata of recent hemorrhage. Red wale marks which are longitudinal red streaks. Cherry red spots which are flat discrete spots. Hematocystic spots, raised discrete spots. And diffuse erythema. Previous variceal hemorrhage. 70% of patients will have further variceal bleeds after an index bleed, risk highest in first 48 hours after first bleed. 30% re-bleed within 6 weeks, 30% re-bleed after 6 weeks. Lastly, for chronic management, start patient on an ablation regimen. Endoscopy with initial ligation or sclerotherapy, and subsequent endoscopic monitoring, and repeated ligation or sclerotherapy is required to completely ablate varices. If patient bleeds again, suggesting failed ablation, to consider shunt surgery. Propranolol, PPI, acid suppressive therapy is theorized to improve the stability of clot. That's all for this video. Thank you.